All right, here we go. It is Wednesday. It's week 6, thoracic spine. We started that actually on Tuesday. We're continuing with that today. It's the winter of 2021. You are responsible. I know we didn't have class this week, but you're still responsible for this material. So let's continue the osteology story. So the articular processes, always kind of confusing for students, I think. But here it's these little rabbit ears sticking up. And then the facet, let's change colors there. The facet for the superior articular process is right here. Inferior articular process is down here. You can't see the facet, right? But the facet would be on the other side of this. So inferior articular process, superior articular process. The facet orientation is also quite interesting. The superior articular process facets face mostly backwards, and the inferior articular processes face mostly forwards. And they're common. It's common for these to be asymmetrical, so you can see facet tropism in this region. So how does that affect the motion segment, the thoracic motion segment? Well, if the facets are facing front and back, you can do a lot of rotation, but flexion and extension would be very limited, and that's exactly how the thoracic spine behaves itself. It's also, the research shows that the zygapophyseal joint or the facet joint or the Z joint, whatever you want to call it, is not that sensitive to pain. Studies have found fewer nociceptors, which carry pain, in these thoracic Z joints compared to cervical and lumbar. The synovial folds are also very small, so it's less likely that you can get one of those synovial folds entrapped and pinched. So people with terrible thoracic spine pain is not going to come into your office that often. The vertebral canal is fairly round looking. You can see it right here. And yeah, remember that makes up part of the vertebral foramen, multiple vertebral canals. And yeah, it's smaller when compared to the cervical and lumbar. What about the spinous process? These are interesting. So 1 through 4, T1 through 4 project pretty much like lumbar, straight backwards. 9 through 12 also project more posteriorly. 5 and 8 are crazy. They actually project more inferiorly, which is kind of strange, but you can see them right here. Can you actually pick out where T5 and T8 are? Well, we said that they project really inferiorly, and so look at these things are kind of pointing straight down. There's the spinous processes. And when you do palpation next quarter, you actually have to go up 2 interspinous spaces and then over to find the transverse process. They're that vertical, and you can tell here we're away from T8 because that one's coming straight back. So that's kind of the deal with that. So that's 5 through 8 there. I would never test you on that, but if I stuck this picture on the test, put a star on this spinous process, I'd say, is that upper thoracic, mid thoracic, or lower thoracic? You should know that that's mid thoracic because they point straight down. The intervertebral foramen are actually really big compared to the spinal nerve. And that's not so much that they're huge, it's that the spinal nerve seems to be a little smaller. They are big too, just the bony hole is big. And the borders are pretty much the same as we've discussed of the intervertebral foramen, or aka neuroforamen. But there's a new player here. The rib head is also one of the borders, and that's a little unusual. Everything else we've seen before. T1 through T5 intervertebral foramens, they're the ones that have a rib making up part of their border. It's not true for T11 and T12. And they face laterally. So here's a patient of mine this year, but you can just see it's a CT sliced through the neuroforamen of T11. It's huge. It's massive. It's much bigger than there's T12, and it gets smaller as you go down. So they're very, They're very big. All right, so the ratio between the spinal nerve and the neuroforamen is only 8%. So the spinal nerve only occupies 8% of the volume of the IVF. Cervical are huge. They're 50%, that ratio between the spinal nerve and the volume of the neuroforamen. Lumbar is about 33%. So this is why you're probably going to see very few cases of thoracic radiculopathy and radicular pain, pain wrapping around the chest, which is where the intercostal nerves go. The anterior ramus makes up the intercostal nerve. You don't see that very often. Very rarely do I see people with thoracic problems. Fun facts. So it's obviously there's 12 bones, so it's longer than any other region in the spine. Because it has ribs attached to most of the bones, the motion segments have very little independent motion. They're anchored down. It's almost like a naturally occurring fusion. So that's interesting. The posterior lateral edges of the superior upper thoracic vertebrae sometimes have some remnants of the uncinate process. So you'll understand that more when we look at T1. And the size generally increases as you go superior to inferior. Interesting, some more fun facts. Normally, the normally concave, the lateral surfaces of all vertebrae are somewhat concave. But on the left side of thoracic vertebrae, they're pretty straight. There's not much concavity to them. And why is that? It's because this abdominal aorta is pulsatile from systole. It shoots a huge blast of blood out here. And it's sort of eroded the left lateral surface of the vertebral bodies because of that pulsatile aorta. The lower thoracic vertebrae take on more characteristics of lumbar vertebrae. That's intuitive. Same with the upper thoracic vertebrae take on characteristics of cervical. In fact, T12 is very difficult to tell apart from T1 if I just have the bones laying out on the table. Although there is some, I shouldn't say that because there is the costal facets, right? The lumbar vertebrae don't have a facet for the articulation of the rib head, so you can tell it apart. And it has these stubby little transverse processes as well. T3 is the smallest in the entire thoracic spine. These are definitely fun facts. Lateral osteophytes, so if you have little bone points coming off thoracic spine, they're much more common on the right lateral side of the vertebrae. Why? Because of that pulsatile aorta again, kind of smooths over that left side, so you don't see osteophytes. We used to have a cadaver that looked exactly like that. Tons of osteophytes on the left lateral or on the right lateral side. Nothing on the left because of that aorta. Spondylolysis, so broken pars with a slip forward is very rare because of the ribs give such great support to the thoracic motion segment. All right, let's talk about ribs now. Always a board favorite. There's your student anatomy, Gray's Anatomy for students, as the author is Drake here. So there's 12 pairs of ribs, of course, and posteriorly they connect to the thoracic vertebrae. I think we probably already talked about that, right? There's costal facets and costal demifacets where they attach, and anteriorly they attach into the sternum. And all 12 connect posteriorly to at least one thoracic vertebrae. So every rib connects to the body. There's no exception. And you shouldn't have ribs, quote, normally in the cervical or lumbar spine, and that can be trouble when you do, especially in the cervical spine. So let's take a look at the sternum. So the sternum is, and people get this very simple question wrong. It's like, why are you talking about? That's not the spine. It actually is considered part of the axial skeleton, and that's our domain. So yeah, it is part of the spine in a way. It's a part of the axial skeleton. It anchors the anterior ribs. It also protects the heart underneath it. Heart would be right under this thing. Not completely, though. It's made of 3 parts. That's a really easy softball question. You can't miss questions like that. Manubrium, body, xiphoid process. The manubrium, let's talk about that. That's the little shield. I think that means shield in Latin, if I remember right. But there's the manubrium. It has 3 little notches or indentations. There's the jugular notch right here in the upper portion, which really doesn't do anything. And then we have a clavicular notch right here, and that attaches to the clavicle. And in fact, it forms an important joint, which people are going to mess up and get dislocated, called the sternoclavicular joint. And on the lateral part of the manubrium, there is also a facet right here for the attachment of rib number 1. So there's 3 little notches or depressions on the manubrium, but only 2 of them actually connect anything. And then there's even a little bit more. There's a kind of a demifacet, if you will, even though you don't call that. Well, actually, it is calling it a demifacet here in this in Cramer, because rib number 2 is shared between this. I guess you could call that the inferior demifacet, and that would be the superior demifacet. Then we got the old sternal angle of Louis we need to talk about. So this region right here, hopefully you can see my pointer, I didn't think of that. That's where the manubrium and the body of the sternum connect together. That forms the manubrial sternal joint, and it's usually raised up. It usually has a little lip of bone here, and that has an important name. That's called the sternal angle of Louis, or just the sternal angle. So you definitely want to know that. This joint is like the pubic symphysis, is the same type as the pubic symphysis. It's a symphysis type joint. But occasionally you can get a synovial joint out of this and have a diarthrodial joint, and it's movable. But it's pretty rare, probably under 1%. Sternal angle of Louis is always important. If you stick a horizontal plane through the sternal angle of Louis here, and it slices right through the body, there are some important landmarks that this slice goes through, and these are very high yield board stuff right here. So horizontal plane running through the sternal angle of Louis. So what do we know about this horizontal line? Well, first of all, we learn in palpation, if you find the sternal angle of Louis and palpate out, you actually hit the second ribs here. So that's important. It also, if you push the plane deep through the body, it goes through the T4 intervertebral disc, so kind of halfway between T4 and T5. It also hits the bifurcation of the trachea, where the trachea becomes the right and left mainstem bronchi. It also passes through the hyla of the lungs, which you'll learn next quarter about. But that's where all the arteries go into the lungs, and that's also where the mainstem bronchi enter the lungs, and you can see it radiographically. It's also at the level of the superiormost part of the aortic arch, and it separates the superior from the inferior mediastinum as well. Cramer forgot to put that one in there, but that's important. You'll learn that next quarter as well. Okay, what about the body of the sternum? If you look closely, you can see there's 4 segments here. It kind of looks like the sacrum, doesn't it? In fact, those are embryological remnants, very similar to the vertebral bodies, and therefore they get a name. Those are called the sternobrae. Sternobrae, like vertebrae, only sternobrae. Right? I didn't put this slide in. This is new. You guys are the first ones to learn that. So there are 4 full-blown costal facets here, but the as we learned, I think we learned it. I'm actually doing this one now. I'm going to be doing your Tuesday lecture live here in a little while. But these are full kind of demifacets, but the ribs don't attach here. There's a costal cartilage that actually attaches in here. And notice there is a little nunner demifacet, or half a facet here. right down here. See that? So the seventh rib, kind of its costal cartilage is split between the xiphoid process and this inferior part of the sternum. Xiphoid process, so you have to be careful when you're learning CPR, because in people over 40 it tends to ossify, right? There's the piece of it right there. And so this can turn to bone once you get over 40. So if you're doing CPR, you don't want to have your hands on this thing or you will break it off. So you have to be very careful, and then you'll get sued. Okay, it's also a symphysis type joint, but it ossifies, so there's no synovial fluid in that thing. And as we said, laterally it contains a half a facet for the articulation of rib 7. Let's dig into these ribs a little bit more. So only ribs 1 through 7 directly connect to the sternum via this costal cartilage. Is that true? Let's count them. Well, yeah, so there's 1, rib 2, 3, 4, 5, 6, and 7. So sure, there are little facets there for all 7 of those. Therefore, the ribs 1 through T1 through T7, those are called true ribs, because they truly connect to the sternum. All right, so you definitely need to know that. That's another easy question. I ask that in just about every test. So the 5 lower ones, T8, T9, T10, T11, T12, those are called false ribs according to Drake. Cramer's a little off on this one, but we'll go with Drake because he's been around forever. So those are false ribs because they don't articulate directly into the sternum. That's what false ribs are. Now T11 and T12, they don't even join any type of costal. They have no costal cartilage. So there's no connection to the sternum. We'll see here in a minute that T8 and T12 connect to the costal cartilage kind of indirectly. So they still, T8 through T12, still have a connection with the sternum, but it's kind of indirect. But that's not true with T11 and T12. Those are called floating ribs. Floating ribs. And yep, you can see the costal cartilage here. Kind of looks like a rib, but it's made of cartilage, so you can't break it here. You can dislocate it, right? This costal cartilage joint right here, you can dislocate that. Very, very painful. But you can see all 7 connect. But you can also see 10, 9, and 8. They kind of share a piece of costal cartilage here, which morphs into T7's costal cartilage. This is really important. This is called the costal margin. And we use that over and over in 5th quarter when we do the GI exam. The costal margin is an important boundary that you need to know. It separates the thoracic cavity from the abdominal cavity. Right, just kind of a blow up of that. Costal cartilage of, as I just said, 7 through 10 form a single strip, as I just showed you, and that's called the costal margin. Separates the abdominal from the thoracic cavity, morphs into the costal cartilage of T7, everything I just said. So technically the costal cartilage is made up of shared costal cartilage from T7 through T10. Right, there it is again. All right, let's meet the rib cage. There's a real skeleton there, real human skeleton. Get a little water here. Yeah, so that's the rib cage. So it's like a cage of bone and cartilage around the thoracic cavity. So it protects the lungs and the heart mainly. It also is connected posteriorly to the spine, and it's connected anteriorly to the sternum. Now, these costal cartilages and this anterior cartilage can be very anomalous, right? We can even see right here, see how these two have grown together? So that's definitely weird. Same thing over here. So there's a lot of anomalies you can see on x-ray. It loves to be calcified too. You'll see calcified flakes in here all the time. No big deal though. Yeah, so again, technically the ribs don't connect to the sternum. They use the costal cartilage. We've already said that. Typical ribs. So those are, from Drake again, those are ribs 3 through 9. So some of those are true ribs as well, but here's another concept is typical ribs. So now we're talking more about the osteology of the rib. So typical ribs have a head, neck, and tubercle. I think we went over that yesterday. The anterior end articulates with the costal cartilage, posterior with the vertebral column. We said that again. Via, though, because here's an anterior rib right here. See, it articulates with the sternum, but via the costal cartilage here. Okay, there's a PA view. There's no costal cartilage from a PA view, right? Posterior to anterior view, or a view from the back. Do you see any costal cartilage? No, you got straight up bone coming in here. Right? The rib has 3 basic parts. So it has a head, a neck, a tubercle, and a shaft. So there's some little tidbits about that, but let's just get into this thing. So here we go. This is what we're going to do. My little lab talk today is exactly this, what I'm going to tell you now. So we have the head. Let's see, maybe blue would work here. There's the head. The tubercle would be right from here to here. And there's facets. There's 2 facets on the head, and there's 1 facet on this tubercle. This is called the neck in between. And the rest of it is the shaft. And we can see toward the anterior, you could always tell which is the anterior because the anterior is really flat. And the posterior, well, it has a head, neck, and tubercle there. The curve or the angle of the rib is right here. It's usually just a little bit away from the tubercle. That's a very high probability site for fracture, certain types of injury. Alright, so there, I guess I could have just dropped over there and not had to draw that. But there we go. The posterior, where's the anterior and the posterior end? The posterior end, when you say posterior end of the rib, it includes the head, neck, and the tubercle, but the shaft starts right here after the tubercle. So this is all rib shaft. Got it? There's some general, surgeons use this more than anything else, but there's the posterior rib as the head, the neck, the tubercle, and the angle. And right after, I mean, the angle is the demarcation zone where the posterior lateral rib comes. And then we have a lateral rib here, and then we have an anterior rib here. So those are kind of the general locations of a rib. And that angle, as I said, it's a high risk area for fracture, and depending on the injury. And again, where is the angle? Well, it's just a little bit, this region right about in here is where most curving occurs in this patient. And as you can see over on this side, we got fracture here, we got fracture here, fracture here, fracture here. This person's messed up, right? Another fracture and dislocation here, so another fracture here, so all sorts of trouble. Alright, the rib head, so that's at the posterior end. That's the most proximal end, or most posterior part of the rib. It articulates typically with 2 vertebral bodies via a superior and inferior costal demifacet. Make sure you know that the same numbered rib always connects to the superior costal facet. So this is kind of a cool picture here. It's see-through, so we can see the rib, but they made the rib see-through so we can see the transverse process, which would normally, the rib would normally hide it. So we can see a transverse costal facet, which would be hidden by the rib. And then we can see a superior costal facet right there. Or I'm sorry, an inferior costal demifacet. And here's the superior costal demifacet here on the vertebral bodies. So these are on the vertebral bodies. And therefore the great board question, and any question, is if this is T6, and I didn't have these numbers here, how would you label these bones? Well, the superior always bonds, so the superior demifacet S always bonds, or the rib always bonds to the superior demifacet. So we would look for the superior demifacet, and that would tell us that this is T6 and this is T5. Okay, so that's an important concept. So the same numbered rib always connects to the superior costal facet. It connects to the inferior costal facet of the bone above, but that will always be one lower. So this is T5, this is T6. So make sure, guaranteed questions on the test on that and on boards. All right, demifacets. Yep, everything we said. There's a superior and inferior demifacet. There's also, or actually, this is on the rib head. So what connects to those superior and inferior costal demifacets on the vertebral body? The rib head has a superior and inferior facet, articular facet, that connects to them. Right? In a diarthroidal joint, you have to have two facets. And we'll look at that here in a second. There's also a bony crest that separates those two. There's even an interarticular ligament that runs between them. Okay, so here is the deal. So this one, that's the superior articular facet of the rib head. This is the inferior articular facet of the rib head, and you should know who these connect to. So, because it's let's do this one. The superior articular facet of the rib head actually connects to the inferior costal demifacet of the bone above. So be careful. This is a tricky region. Right? This inferior articular facet of the rib head, that will articulate with the superior costal demifacet. Got it? The neck of the rib is right here. We'll look at some ligaments. Costotransverse ligament arises from that. And the superior costal transverse ligament. That's about its claim to fame right there. And yep, there's the region. So the neck of the rib is between the tubercle of the rib and between the head of the rib. Where tubercle is between the neck and the shaft of the rib. This has one articular facet, and that's what hooks up with the transverse costal facet on the transverse process. All right, let's see. There's also a non-articular part. So where's the non-articular part? So all of this stuff, that's the non-articular part. All right. Yep, there's just another look at it. And the lateral costotransverse ligament attaches to this non-articular part here. Remember the articular facet of the tubercle, that hooks up with the transverse costal facet on the transverse process of the vertebral body, of the same number, by the way. See, this rib stuff can get a little tricky. The shaft begins immediately distal. Actually, that would be proximal, immediately distal to the articular tubercle. Well, it depends how you define distal. It would be more anterior, I think is probably a better word. Anterior. I'll show you a picture here in a second. And it extends to the end of the anterior part of the rib where it merges with costal cartilage. Right, so the shaft would be all of this. This is anterior, that's posterior. Right, let's see, what else do we need to say about this? We've really talked about the angle already. Don't need to say that, I could probably take this slide out. A lot of the curve occurs at the angle. It's also where fractures occur. And angle usually is about a few centimeters, kind of distal or lateral to. Cramer uses that word distal, which kind of seems weird to me. I thought that would be more proximal. But yeah, that's going to be confusing. I like the word lateral better. Costal groove is a very important concept for spinal anatomy and next quarters anatomy as well. So these ribs have some meat between them. I mean, just like ribs that you go out and eat ribs. They have intercostal muscles. There's an external intercostal muscle, an internal intercostal muscle with fibers running like this. External runs like this. And then you have an innermost intercostal muscle here. And the easy board question is, the neurovascular bundle in the intercostal space runs between what? And it would be the innermost intercostals and the internal intercostal muscles. And then, which is on the lab sheet, you need to know this order right here. So this is superior up here. This is A to P view, but superior inferior here. So the costal groove contains the neurovascular bundle here. And it's always in this order. It's the mnemonic is VAN, from superior to inferior. So the first one up is the intercostal vein, intercostal artery, and the intercostal nerve. So if you're in medical school learning to put in a chest tube, you always put that tube here. You always crowd the superior part of the rib, even though there is a tiny little neurovascular bundle here, which is not drawn in this. You definitely don't want to put the chest tube here, because you'll hit that intercostal nerve and it'll cause a horrible inflammation. They'll have horrible pain wrapping around their chest. So you have to be careful from that. Right. Okay, we talked about these muscles already. The neurovascular muscle bundle, we already talked about all that. Now what about the atypical ribs? So that is the 1st, 2nd, 5th, 11th, 12th. Those are atypical ribs. So let's go over these. Rib 1 is really flat and it's really horizontally low in orientation. Most of your ribs kind of run vertically, or at least obliquely vertically. But rib 1, that thing is flat and it's horizontal in location. The key with rib number 1 though, it has a big knot on it, which is called the scalene tubercle, and that's where the anterior scalene muscle inserts into, so that's really important. It's also super important to know that the subclavian vein passes anterior to the scalene tubercle. This is super high yield board stuff in my test questions. While the subclavian artery and the posterior trunk of the brachial plexus, they pass posterior to the scalene tubercle, and its attached anterior scalene muscle. And this is a source of something called thoracic outlet syndrome. If you have a super thick anterior scalene, or the rib is fractured and it's healed with a big callus, you can compress the neurovascular bundle. More problematically, you can compress the posterior or the inferior trunk of the brachial plexus, and you can get all sorts of trouble from that. In general, that's called thoracic outlet syndrome. Here's a kind of an overhead view, A to P, but we're looking overhead, and there's a huge scalene tubercle. So the anterior scalene would be attaching right up in here. Posterior or middle scalene would be attaching right here. Or actually the anterior, sorry, I got that messed up. The anterior scalene attaches here, the posterior is back here. But the key is that the vein is up here, and the artery and the nerve, trying out my colors here. I don't know if you can see that yellow. They're behind, they're posterior to that scalene tubercle. Right? And here's just how entrapment can occur. So here's you can't see the tubercle, but you can see the anterior scalene muscle attached to that tubercle we just looked at. And there's the vein, so that's not going to really have any trouble. But the subclavian artery and the inferior trunk of the brachial plexus, there's just one. You can see, you can see the whole ball of wax, how roots come into that as well. You can get this pinched if your middle scaling and anterior scaling get really big, it can pinch this and cause what's generally called, which is a terrible term, thoracic outlet syndrome. So you'll get a lot of instruction on that as you go through the program. What else with this first rib? Posteriorly articulates with usually only one costal facet on the T1 vertebrae. So T1 usually only has one big costal facet and doesn't have an inferior costal demifacet. Sometimes it does, but most of the time it doesn't. Alright, second rib looks more like a normal rib than the first, but it also has a tubercle. In fact, they call it a tuberosity on its superior surface. And that's where the serratus, or is part of the origin for the serratus anterior, is that second rib through that tubercle. Okay, the 10th rib, so that head only has one facet as well. So on T10 there is usually only one single big costal facet. There's no demifacets. Sometimes it might have demifacets, but usually it's a big single costal facet. Sometimes it can attach to the disc, which is a little strange as well. So 11 and 12, pretty similar. So the key with this one is that neither of these vertebrae have a neck or a tubercle. So no neck, no tubercle. So that's kind of weird. These are also considered floating ribs. Sometimes bad AKAs are false ribs, free ribs. Floating rib should be the word that's used here. And there is no costal cartilage, so that they don't attach to the sternum in any way. Okay, let's see, how are we doing on time here? Because I'm not feeling actually the greatest. Had my booster shot yesterday, and man, I woke up at 3 in the morning. I haven't felt like this. Got the flu-like symptoms, just run down and achy. Everything's so achy. My wife didn't get hit as bad as I did, but let's go just a little bit further. Because, well, we're going over these in lab, but let's go over the costovertebral articulations, and then we'll call it a day. So costovertebral, so that must be the junctions between the ribs and vertebrae. And each posterior rib typically articulates with two vertebral bodies through their costal demifacets and one transverse process through the costotransverse facet. These joints are real. They're diarthrodial joints. They have a synovium in them that produces synovial fluid. They have a joint capsule around them. And in general, you can call these collectively the costovertebral joints. And we can get more specific if you want to. So there's two types of costovertebral joints. There's the costocorporeal articulations. And we know what corporal, remember we talked about that. What does that mean, corporal? That's got nothing to do with the army or anything. That means body. So this is the articulation between the rib and the body, or bodies. And then costotransverse articulations is the articulation between the rib and the transverse process of the same number, by the way. So costocorporeal articulations, sometimes they're just called costovertebral joints. That's not the greatest AKA though. I'm sure it'll be costocorporeal articulation. And this is the articulation is between the rib head facets and the superior and inferior costal demifacets, which live on the vertebral body, right? So technically each joint, each costocorporeal articulation, 4 sets of facets are matching up. So we have 2 facets on the rib head, superior and inferior, and then 2 facets on adjacent vertebrae. There's a superior one on the bottom and an inferior on the top. And remember, this is going on there's a right and left. This is going on the other side as well. So remember this setup here. So this is the superior costal demifacet, number 3. Number 7 is the inferior costal demifacet. Number 5 is the transverse costal facet. But the corporal costal articulations are these guys right here, because corporal means body. So this has nothing to do with a costocorporeal articulation. Who meets and kind of bonds with these facets, these demifacets? Well, it's the superior and inferior facets on the rib head that do that. And the weird thing, again, is the superior facet will bind with the inferior costal demifacet. And we'd have to draw another bone in here, because the inferior one would bind with the superior costal demifacet on the rib above. So if this is rib 6, what are these two bones? Well, superior costal demifacet, the S, always binds to the same number rib. So this must be T6, and this must be T5. Got it? Always confusing, I know. Think about it. Make some note cards. So again, these are two true diarthroidal joints, as we said, filled with synovial fluid. We said that the synovial folds are very small, so they usually don't get impinged. It's possible, but they usually don't. And yeah, so here's an overhead view. There's a costal demifacet. It looks like, let's see, these are facing backwards, so this must be a S to I view, right? Because we know the superior articular processes, the facets of those face backwards, so we know this is not from below. So that would be the superior costal demifacet right here, if you want to get specific. Right? And if this is T6, this is the T6 rib as well, if that's the superior, because S to S, S means the same. I know, I hear you. Oh, it's confusing. You can also see the Costotransverse joint back here. And what else do we need to show you? That's about it. But those are Costocorporeal joints. Those that we can't see the other ones though. How about the Costotransverse articulation? So that's made by the facet on the costal tubercle and the transverse costal facet off the TP. Remember, we don't see these at T11 or T12. It's also a true diarthroidal joint. It has capsula synovium. Can get stuck, can be a source of pain. You'll learn how to adjust these ribs as well. Let's see. Do we want to do these ligaments, or because I'm not feeling the greatest. Let's cut it off right there. I think that's enough for today. See you guys later.